Ginny, welcome to the podcast. I have followed your work for a while now, and I know you and I connected shortly after I started my own private practice. And I have just always been so impressed with you and how you combine clinical knowledge with such a compassionate and functional lens. So PCOS is really the women's health RN's wheelhouse, which Ginny runs. So we will be getting into PCOS today as it's a condition that impacts so many women. And I know today's conversation is going to bring some serious clarity for many of you. We also may touch on things like miscarriage and mold and just many of the women's health issues that both Ginny and I come across, and get her functional medical lens on everything. So Ginny, welcome to the show.
I am so happy to be here. I mean, same. I've been following you, and like you're opening your private practice. I've referred clients to you. Whenever someone's pregnant, I'm like, go see your pelvic floor PT. You know, I think it's just so important that we're all just working collaboratively, and I think that's one of the big things that I've really honed in over the past few years of what I'm very good at, and then when to be referring out to other things, if that makes sense. So there are so many smart human beings, and I just want to get everyone on a good care team.
Absolutely. And can you talk for a moment about your medical background and what you do through your practice?
Yes. So I definitely have a pretty, I would say, unique medical background. I think a lot of people ask me like, I get DMs daily like, I'm a nurse in ICU and I want to do what you do. How do I do that? So my background is, yes, I'm a registered nurse. I have my bachelor's degree in nursing, and I had the very unique opportunity right after graduation. I was connected to one of the founders of an organization called FEM, which is a restorative reproductive endocrinology clinic and also a fertility awareness education organization. And so right off the bat, I actually ended up starting to work for them. So I got my hands down deep, nitty gritty in restorative reproductive medicine right away, became a certified FEM instructor, which is a fertility awareness method. So, and then I became their clinical care manager, and I was basically in charge of like all the medical care for all the people going through that organization. So that really allowed me to get my really in-depth knowledge of endocrinology, and so hormones, endocrinology.
Yes.
And so, that experience was so invaluable to my understanding of hormones. Going through that, I was really left, really questioning, how could we help these women from a nutrition and lifestyle perspective? Because, in the background, I was dealing with my own journey of lean PCOS with very little answers from my providers. And I was just seeing these women, they were getting better answers in birth control, but it was still medications.
Yes.
So simultaneously, while I was working for them, I then got my master's degree in nutrition and functional medicine from the University of Western States. And I chose that program very specifically because I wanted that functional medicine perspective. It was not a traditional master's program for dietetics, to become a registered dietitian. So now I'm actually working on my credential to be a CNS, which is a certified nutrition specialist, which is the equivalent to an RD. So I will be able to officially call myself a nutritionist probably by the end of next year. You have to get 1,000 clinical hours. You have to have a master's
Wow.
to do it. So that's really, I say I'm a registered nurse with a master's degree in nutrition and functional medicine. And then that background in restorative reproductive endocrinology, and those two experiences, really marrying those together to be able to do what I do. So unfortunately, I don't have a great path. People are like,
Yeah.
how do I do what you do? And I'm like, I don't know. I always attribute that to God and the Holy Spirit of just putting me in the right places at the right time, being connected to so many wonderful people. And I've just had really unique opportunities. And from there, if you visit my website and my About page, you can now see also the tons of continuing education that I have done in functional medicine since my master's program. So I am a junkie for all things functional medicine, and I have done a lot of courses.
Yes, which I think is why we connected so deeply, because we both have that traditional medical training of being a nurse and being a physical therapist, but then having this bigger picture lens of, okay, how do we take a more functional approach to all of this to really get to the root cause? So, Ginny, what is PCOS? What is polycystic ovarian syndrome to those who are newer to this term?
Yeah, so PCOS is polycystic ovarian syndrome, and I think to be diagnosed, or a way that I like talked about is talk about the diagnostic criteria to be diagnosed with PCOS. So the typical Rotterdam criteria is you have to meet two of the following of the three things to be diagnosed with PCOS. So number one being irregular or absent cycles. So this is called oligomenorrhea or anovulation, or amenorrhea. And then number two is having either elevated androgens based on blood work. So this would be testosterone or DHEAS. And then they're adding to this criteria to then have potentially the clinical signs of elevated androgens. So this would be cystic acne. I always say hair growth where you don't want it, and then no hair growth where you want it. So you have thinning hair, but you can get hair growth on like your chin, chest, and then also potentially weight gain around the abdomen. Not so much part of the criteria. Typically, it's the hair growth in the acne that they'll look at a lot. And then the third part of that is doing an ultrasound to see if you do have cysts on your ovaries. And this is different, I should say, than a singular cyst. You maybe heard of cysts. Polycystic ovarian syndrome, they call it the string of pearls that you'll see on the ovary. And these are actually just a bunch of stimulated follicles or fluid-filled sacs that are all stimulated, but in PCOS, you're having a difficult time creating one maturing follicle. So you just have all of these stimulated little follicles on the ovary, and they're not actual cysts. So I think that's confusing because some people are like, oh, you've heard maybe a woman going to the ER because they had a cyst on their ovary. That is
right.
not PCOS. So hopefully that differentiation makes sense. So again, recapping of those three criteria, the cycles, the elevated androgens or clinical signs of elevated androgens, and then that ultrasound showing that you have those polycystic ovaries. You need to have two of the three to be diagnosed with PCOS.
Okay. Well, thank you for explaining that, because I have had a few patients recently whose physician told them they had PCOS. And when we talk about why it was diagnosed, it really was a diagnosis of exclusion of, okay, you're having irregular cycles. We don't think it's from over-exercising. And they just gave them a diagnosis, and they didn't have an ultrasound completed. They perhaps weren't really checking boxes in those other categories. And so I was very excited to bring you on, because when we look at things from that functional health standpoint, we dive deeper, right? We get to more of, is this actually what's going on? Or is it just a diagnosis that we're throwing a patient's way to, I don't know. It's frustrating. I can't even say why they do it.
Yeah, I think because once you get in conventional medicine, once you get a diagnosis, then that is when the treatment can follow.
Sure.
So, right. So they are so apt to give people a diagnosis, so then they can offer the next step of what their treatment would be. So whether that be traditionally with PCOS, it's going to be birth control if you're not trying to induce pregnancy typically, or potentially metformin, which there's a problem with that, which we can talk about.
Yes.
Maybe spironolactone for acne, because spironolactone it's traditionally a heart medication, but it has the side effect of lowering androgen. So many women will choose that, which can potentially help with the cystic acne. But again, it's not getting to the root. And what I actually say to a lot of clients is, I don't really care if you have a diagnosis of PCOS.
Yes.
It doesn't really help me, because it doesn't tell me why you have PCOS. Right. And this is so important because, right now, like I said, in conventional medicine, it is still barely being recognized, but, it will get recognized, and then they'll just be like straight to metformin. They'll basically just blame blood sugar. Okay. It's like one of the number one reasons for why someone has PCOS. And while about 70% of women with PCOS do struggle with blood sugar issues, and how that can stimulate PCOS, backing up, is if you have high insulin levels from blood sugar dysregulation, that high insulin can trigger the theca cells of the ovary to produce more testosterone. So that's how we can get that cascade of PCOS. Now, based on my research, and I did a lot of research, I've written several research papers about PCOS. It was like one of my focus in my master's degree program, is that based on the research is that while blood sugar can play a role, we also see a lot of other things in the research that can contribute to PCOS or be associated with it, like gut dysbiosis, oxidative stress or inflammation, potentially toxic. I know you talk about like toxic burden. We have
Yeah.
seen environmental toxins and increased toxin load be associated with PCOS as well.
Mm-hmm.
So, and I'd also say increased stress and trauma has also been associated with PCOS. So there's a lot of different areas to be looking at. And what I've really found in my clients is that it's usually not just one thing. It's usually several
Right.
things contributing. And, they don't typically see the best results and feel the best. I think that's a really big thing because sometimes with some of these medications, you can see the change in the hormones in
Mm-hmm.
labs, but physically, someone is still not feeling very good. And at the end of the day, isn't that what it's all about? Isn't about getting someone a higher quality of life? Um,
Right.
and I think that's really what's being missed so much in PCOS.
Yeah. And so if you were to say what the root cause of PCOS is, would it be this kind of bucket of factors? And to your point, that usually it's a few of the different pieces of the puzzle that's contributing to somebody's output of PCOS.
Yes, exactly. And what's crazy, I have this visual on one of my many Instagram posts. Find it for you. But what's crazy is also so all these different signals. So blood sugar imbalances, the high toxic burden or poor detoxification, inflammation, oxidative stress, gut dysbiosis, potentially infections. I didn't mention nutrient deficiencies. Nutrient deficiencies is
Mm-hmm.
huge. I'm trying to think if I'm missing any more. I mentioned stress. And what's crazy enough about all these things is all those can independently be associated with PCOS, but they can also increase each other. So, for example, if you have gut issues or gut dysbiosis, that can increase your risk of nutrient deficiencies. So, it's all cross reactive, if that makes sense. Even in
Mm-hmm.
the graph that I have on my Instagram, it's like pointing on how like poor detox can increase inflammation, then inflammation increases PCOS, but then
Yes.
detox also increases PCOS. Like, right? It's all these different mechanisms that feed back to each other. And I kind of say it's all really a vicious cycle. We're really
Yes.
just getting ourselves into a really big vicious cycle that we need to stop it.
Right. So how do we stop it? What do we do?
So, the first thing that we do in my practice is we do in-depth blood work and a GI map to really try to identify those root causes for someone. Unfortunately, I do find testing to be so helpful. And I say unfortunately because I wish that I could be like, if you have these symptoms, it means this thing. But unfortunately, for example, I'll take nutrient deficiencies, you can have fatigue, right, with that. But you could also have fatigue from blood sugar issues.
Hmm.
So unfortunately, with very generalized symptoms, there can be several root causes. So I found it to be the most helpful to get the targeting lab work done to say, this is what we are really seeing. And then, yes, we will marry that with someone's clinical picture and diet and lifestyle. So, for example, I had a client actually today with PCOS, very clear PCOS from her, blood work, her ultrasound she had done, not by me, by another provider.
Hmm.
And her glucose markers, her blood sugar markers came back normal for just the fasting ones. But I took a look at her diet and I was like, no way that your blood sugar is okay. She had like just told me she just had a bagel for breakfast. And no hate, no shade, but I was like,
Yeah.
we always want to look at the person, their labs, and the whole clinical picture together and not just get bogged down in one thing. Um,
Right.
so yeah, I would say, to get started, like I said, blood sugar, as much as I said it's not the only thing, it can be a huge factor. And we focus on blood sugar with all of our clients. So, we do see more than just PCOS. We do fertility, general PMS, all those things. And we are focusing with blood sugar with everyone because of how important that is. And so, some of the first places people can start out with blood sugar would be, not having any naked, I say naked carbohydrates, always pairing a carbohydrate with a protein source. Try
Hmm.
not to go more than 6 hours between meals. And actually, this is like in the metabolism world. I don't know if you remember, like we were like the 6 meals a day is like good for your metabolism.
Right.
Research has actually been showing that it's actually better to have more of like 3 square meals a day. Of
Okay.
course, this will be so dependent on your season of life. If you're breastfeeding, you're pregnant, what's going on.
Yes.
But, general recommendation, if you are not in those seasons of life, 3, and actually sometimes I say 4 square meals a day would be my, how we're working on blood sugar with people. So they're getting optimal time between meals, which is great for your gut, great for your blood sugar again. But sometimes it's hard for women to meet all of their caloric needs in 3 meals a day. So I'll do, 4 meals a day with them. And that seems to be a really good middle ground for a lot of people. And then getting optimal protein with, again, I already mentioned that, but I would say upwards of 30 grams of protein with each meal. And fiber is also huge for blood sugar. I think there's this huge move for protein, which I love.
Right.
But I think people are forgetting about fiber.
Yeah. Yeah.
We have the most studies on fiber and the benefits on human health than almost any other nutritional ingredient. And I think it's like breathtaking. We have, if you know, a meta-analysis.
Yes, of course.
Which is basically when you take a bunch of studies and then you're synthesizing the information from all of those studies. We have meta-analyses on the benefit of fiber on human health. I love fiber. It's so great for your gut, but so wonderful for your blood sugar. And most Americans are getting maybe 14 grams of fiber a day. And so we really want upwards of 25 to 35 grams a day of fiber. So that is huge. So I'll take a hot sec break because I'm going on. I can talk a lot. But
all the good things. Now, what are your favorite fiber sources? Because I completely agree. I talk with my clients as a physical therapist a lot about protein consumption because we're rebuilding muscle mass, and that's really important for healing of their pelvic floor and their deep core and the benefits of certain types of protein like collagen, all of that good stuff, but their body needs to absorb it. And yes, to your point, I am hearing more and more just out there of women having a hard time digesting the amount of protein that they're consuming. And I'm sure a big part of that is they might not be getting enough fiber. Yeah. So what are your favorite sources of fiber, and how does that contribute to this like gassiness that some women have with protein consumption?
Okay, so now we're going to get into a bit of gut health, which I love this talk. So, okay, I'd actually would love to back up and say if a woman is having an issue digesting protein, that is actually going to more point to stomach acid production. So your stomach acid is so important for breaking down your protein and then also vitamin B12. So if you are eating a lot of protein and you're like immediately feeling like bloated afterwards, you're not feeling good, you're probably not producing enough stomach acid to digest your protein. And then that kind of goes into what helps us to produce our stomach acid. We need zinc and sodium to produce stomach acid. If we have a bacteria called H. pylori, that could negatively impact our production of stomach acid. Or if we have poor meal habits. So if you are not adequately chewing your food, so I say always trying to chew to applesauce consistency. If you're not chewing your food, if you're eating in a distracted state on your phone, busy, working, all those things, you are not going to be able to produce your digestive secretions well. So, and one of your digestive secretions being that stomach acid. So I would say, backing up, I'm like, okay, whoa, actually, is there a digestion issue here?
Right.
So I think of fiber as like feeding our healthy gut bugs, right? And so best sources of fiber, you have different kinds, insoluble, soluble fiber, but just kind of giving like a good list that will give you a mix of both. Definitely your fruits. I am a huge, huge fan of fruit. Your flax, your chia seeds, I definitely recommend those a lot to clients because they will give you a really big fiber boost. Then your starchy veggies, so your sweet potatoes, your regular potatoes, your squash, and then you have your whole grains like your rice, beans. I want to say that's a whole grain, that's a legume, sorry. But your beans kind of category, chickpeas, lentils, all that good stuff. And then, yes, your whole grains, oatmeal, quinoa, popcorn, underrated source of fiber. I'm just going to say that. Underrated. I
love it. I love a good popcorn snack. So that is good to know.
Homemade. Make it homemade in coconut oil.
Yes.
And your family will love it. I turned my whole family was, Orville, whatever. I think that's the brand. But I made them all my homemade. Everyone makes fun of me, like Ginny, like the holistic, whatever. They usually like, Ginny's healthy stuff. You don't want to eat it, but I made them all my popcorn, and now it's the only popcorn they'll eat, which is for my family very impressive.
That is huge. I also make it on the stovetop, and it won my husband's taste buds over, and he too was like, microwave in a bag popcorn guy, like loves a popcorn snack. And I make it on the stovetop with coconut oil. So easy.
So good.
And he loves it. Well, now we're getting our fiber in. So that's perfect. Now, I do want to ask in terms of blood sugar and you mentioning those 3 square meals a day, fasting. Let's talk about that for a moment. So what are your thoughts on fasting when it comes to blood sugar and hormone health?
So first, a lot of research on fasting is done in men, especially like the long 16-hour fasts. But actually research has also been done, and this is also for males too, which I tell this to my men all the time because I think it is crucial, is that it's actually been shown in research that when you fast earlier in the evening and break your fast early in the morning to have breakfast, that has benefits on blood sugar. Whereas if you fast starting late into the evening, say your like last meal is like 8, 9 p.m., and now you're fasting into your morning and skipping breakfast, that actually has been shown to have negative effects on your blood sugar for men, and I would assume also women.
Right.
So I'm a really big fan of a 12-hour minimum between your dinner and your breakfast, but always eating within an hour of waking. So if this is making sense, like making sure your fast is starting earlier in the evening and you're not waiting too long to eat in the morning. Breakfast has really been shown, and this again in the research, I love research as you can tell, breakfast has been shown to be so beneficial for blood sugar regulation. And those who have like a good solid breakfast have way better glucose regulation throughout the rest of the day versus those who are breakfast skippers. So I am a really big fan of breakfast. So any fasting that would involve skipping breakfast, I'm not a fan of. And then we have to then talk about like, okay, we'll say you're eating breakfast. Okay, you're eating within like likely about an hour of waking. Could you do like a 14-16 and you start your fast maybe at like 6 p.m.? And I think that's really dependent on the person. And honestly, like if they're able to get enough calories in the day. My big fear with like any longer fast than like a 12-hour minimum, and backing up to the research really says like a 12-hour minimum between dinner and breakfast is great for blood sugar and really good for your gut. You need that downtime.
Right.
You need that downtime to repair itself. When you're eating and your gut is actively digesting, it's not able to repair itself. So again, minimum, but then the beyond that of like 14, 16 hours. If it's causing you to skip breakfast, then absolutely not.
Yes.
But if it's, you're doing it early in the evening, I think it's probably just dependent on the person. And again, what is the state of their hormones? I think really what I've seen in clinical practice is just women's resiliency is so different. One person, I think it really is, I'm not a genetics like I don't usually blame things on genetics, but I really do find like, some person like my best friend, oh my God, that girl can undereat, exercise all day long, and her period stays perfect.
Sure. Yes.
Like I start running and my period is like
right.
So I think people have really their different thresholds of stress, and fasting could be seen as a stress. And again, especially as you can tell, I'm a very nuanced person, especially if it's causing you to decrease your calorie intake for the whole day, right? Because if you're not spending less time eating, well, your calories are probably
nutrient deficiencies can come into play, all of that. So for an individual with PCOS who is struggling to lose weight, and that is one of her goals for, she's hoping to conceive within the next 6 months, would fasting be an option for her with that focus on, shifting to an earlier in the evening fast and still eating within an hour of waking?
I would say potentially yes. I think that would be acceptable. And like I said, it would really see how that person's responding to it. I have weight loss. You brought that up. I have really changed a lot of opinions on that over the years. I think I used to say like, it's not calories in, it's only like it's hormone, like, but really, and again, this is my strong, just being in the research, like that's the law of thermodynamics. Like it is calories in and calories out. However, you can absolutely modify your body's ability to burn more calories through many different mechanisms, right?
Right.
So, with weight loss, like you do have to be in somewhat of a calorie deficit, but there's so much nuance into that because if you are balancing your blood sugar, you're going to decrease your cravings. you're going to probably decrease the amount that you're eating, right? If you are pulling up on more protein, protein is much more satiating than carbohydrates. So you're going to feel more satiated. Same with fiber. Fiber also really helps with satiation. So if you are really focused on these principles of blood sugar and maybe doing a healthy 14-hour fast between like dinner and breakfast and still getting in that breakfast, you're probably going to modify your appetite hormone, right, and your satiety hormone, and you'll naturally decrease calorie intake instead of having to be in this very strict, like counting macros, calories, and calories.
Absolutely.
So I think just I'm very much, I've been I'm on social media a lot, but I'm over social media because there's basically like, I see two different camps in the weight loss,
Yes.
like, you can just like not track and like, whatever and lose weight. It's not about calories in, calories out at all. It's just about your hormones and let's sell you this program.
Right.
Versus people, it's like, you only need to track macros. You can eat whatever you want as long as it's within your macros. And I really just think there's a middle ground there.
Absolutely. And to your point of the word nuanced, I use that word so much as well because it's not all black and white. And when you're on social media, it is, because polarizing topics are what sell and are what get views. And so what we are fed kind of on that About You feed is this black and white kind of polarizing topic. But when you're a clinical medical professional such as Ginny and myself, we see it so nuanced because there are so many pieces of the puzzle, and for each person it is different. So yes, bringing you all a conversation today where we do want you to walk away with actionable steps that you can have some light bulb moments from this conversation of, oh, maybe that would make sense to try for myself, but also understanding that so much of this is nuanced, and the only true way to know 100% what is going to be best for you is to work one-on-one with a provider such as Ginny or myself, depending on what your goals are and what your concerns are.
Absolutely. It's so hard. I really struggle with social media these days because I like want to respond to some videos, but I absolutely do not want to catch that heat. I'm not about to have any social media debates. Like,
Right.
it's just something that I decided when I first started with like 4 followers, I was like, if someone ever says anything negative about me, like, I'm just not going to respond, or, tries to fight with me. I'm just not going to respond and give that any sort of attention or energy because I don't have any of that to give.
Right.
So, I think also too, there is so much you can do on your own, but it is going to be a bit of trial and error when you're doing it yourself, which is not necessarily bad. I just think that you need to know that, right? If you are, not a trained professional, obviously you don't specialize in this. I've spent my day and night researching this. I have a master's degree in it. I'm probably going to help you get to where you want a little faster, but certainly there's so much information on the internet and, so much trial that you can do yourself to figure out what feels best for you. And, that's how I personally got to where I am, was trial and error myself. Took me 7+ years, wish it didn't, but I figured it out eventually.
Right. And I had a similar story. So I think it's neat, to come to those realizations, both just in our personal life, but then working with patients, you see all of the different factors and how each person is so different. And I think that's where that clinical mind really does, to your point, help the patient get there faster versus trying to figure out all those puzzle pieces on your own. Which brings me to lab work. So you mentioned ordering labs previously, and I know you've talked about this in the past of normal, like what a traditional or conventional medicine doctor may write off as normal. Your labs are normal. How often do you see clients come to you with normal labs, but you look at them and it's not optimal?
Every day, every single day. And I will always give credit to my mentor, Dr. Brian Walsh. He was a professor in my master's degree program, and the way he thinks is just incredible. And so I did his practitioner program. His company, I believe, is called Metabolic Fitness, and they have this blood chemistry interpretation program. So that is where I am trained through for like blood chemistry and where I'm getting these optimal ranges from. So I always like to educate that, the ranges that you're seeing if you go to your typical lab like Quest or LabCorp is not based on any research. It's based on the average of everybody getting labs done and 2 standard deviations. So it is, again, not based on any clinical research of what is optimal or good. So with my ranges, Dr. Walsh has done a ton of research into what is optimal and what it could mean if something is off. So, that is where my training comes from. And then with hormones, again, I was so blessed to work with FEM, and I use their hormone ranges. So I'll actually give you an example of a client that I saw today for her lab ranges. So for example, her testosterone was 70, and that was not flagged by the lab as high. Whereas for me, anything over 45 for testosterone is high. So 70 is very high. And then with DHEAS, my lab ranges are 150 to 250. And I had her, she was 350, and it was not flagged by the lab as high.
Okay.
So that is huge. Yeah, and then the same kind of goes for blood sugar markers. So, some of the big ones, and that's some, ones that you could order yourself, like, or, ask your doctor that they're typically willing to order: a fasting insulin, a fasting glucose, a hemoglobin A1C. So, my ranges for a fasting insulin is under 8. I believe the range is over 20 is normal.
Okay. Again, huge difference. Because somebody sees 8 and they're like, wow, I'm well below 20. Like, I'm good.
Yep, exactly. So, we had, so I see people with like 12, 13, and that's elevated, but that's not going to be flagged by the lab. So, the ranges that you use, are huge. I mean, they are huge. And unfortunately, our doctors are just not getting trained right now in these optimal lab ranges. I'm hoping that will change. And, it is hard. You know this probably, but, for like research to catch up to practice, it takes about 17 years.
Yes.
So, right, if we're seeing now that, in these, studies now that we want a fasting insulin around under 8, that's not going to catch up to clinical practice till 17 years from now. So that's
right.
Tough.
It is. And educating people on why it makes sense to consult a provider such as yourself, who's going to look at it from more of this functional medicine lens, is so important because of that 17-year gap of the values that they are taught. And then also that lab ranges that they're given are a standard deviation from the average of everybody around you. Well, if everybody is not metabolically healthy, we are going to keep seeing these ranges change towards non-healthier ranges, right?
What I always say, I'm like, who are the people getting labs done? Probably people who are not feeling well.
Right.
People who are healthy. Those are, if you're healthy, you're not getting a lot of labs done because you are not concerned. So it's very concerning. I would say the lab ranges, and I'll flip this on its head and say I've seen functional medicine providers, their ranges, there's no basis for their range.
Sure.
Where did you get this range from? And they don't have an answer. I had one tell me, like, you just have to trust me. I'm like, that's not acceptable. Like, I'm sorry, we do need research. Like, I always say I'm evidence-based. I'm not evidence beholden because, things in, in natural health and medicine are not always being studied as regular. Well, I'm going to try to say it. You know what I'm trying to say? Not being studied well.
Right.
Like castor oil packs, like, we'll use those in practice and we see good results, but they don't have a lot of research on it. But, with lab ranges, that's not something you want to just play around with.
Absolutely. Yeah, especially if we're diving into an issue such as PCOS and a goal of conceiving, and this is hindering that ability because of irregular cycles and irregular ovulation, all of that.
Exactly. You want to know what is the issue. Is blood sugar actually an issue? Because we need to know that. So lab work is definitely part of the puzzle for us.
Now, Ginny, I would like to shift gears a minute and chat about your personal journey some. So we were talking off air a little bit before we hopped on the call, and Ginny mentioned earlier in this conversation her journey of PCOS and kind of figuring it all out on her own. And then recently she opened up to me about a miscarriage. And Ginny, would you be okay with talking a little bit about that and kind of the root cause of why you think that may have happened for you after 2 healthy baby girls?
Yeah. And for anyone who doesn't know, my background is I was diagnosed with PCOS, a lot of no answers from my medical providers, spent a lot of years trying to figure out it for myself. And it really came for me, it was over exercising, under eating, had an underlying candida infection in my gut, nutrient deficiencies. So, when I really took the time to nourish myself properly, I took a step back from intense working out. My cycles became regular, and I did conceive both my girls naturally, relatively quickly. And as we know, PCOS is, I believe right now, one of the number one causes of infertility because it causes anovulation. So, that was huge. I was told by OBGYN, she was just like, go on birth control and come back when you want to get pregnant.
I was told the exact same thing. Yep.
And that was so concerning to me. So, so it was through all those, different trials. I've tried every single diet under the sun, and I can tell you the best diet that I've had is no diet.
Yes.
I cannot label myself as anything. I eat healthy. I don't know how else to, say it. I eat, how I teach my clients. Truly, I do. So with all that being said, I have my 2 healthy girls, and it's crazy enough because it was like our first cycle, like not fully avoiding,
Yes.
as a certified fertility awareness instructor. So we were a little shocked that we got pregnant. And I was simultaneously still breastfeeding, my daughter at that time. And we had a really early miscarriage, 5 weeks. So, I only knew I was pregnant for a week, miscarried. Now, I did not do any testing, for myself, like before then, or I did not test progesterone. If you've talked about progesterone at all on your podcast at this point.
I have, yes.
So I did not do any testing, and, so I didn't know if it was low is my point. And I've always known this about my body as, with that history of like, over-exercising, under-eating really negatively impacting my hormones. I know that big stressors on the body, and I would consider breastfeeding a very big stressor on the body. I don't get my cycles back until like I'm like not nursing in the night at all. If I start nursing in the night, like my cycle goes right away, so I definitely know that breastfeeding really does impact my hormones a lot. So I think that was maybe tied to it. Probably didn't have maybe the best quality ovulation, maybe had some low progesterone, leading to miscarriage. And, the body is so smart. I know people don't like to hear that when a bad thing has happened, but, I do like to think, clearly my body was not in a place to support a pregnancy at that time. So from there, I went and did my own comprehensive blood lab panel. To see, hey, is anything crazy going on? And honestly, like my levels looked really good. Like my blood sugar looked incredible. My nutrients were a little bit on like the lower end of where I'd like to see it. Not horribly low, but definitely on the lower end. So again, I was breastfeeding for over a year. So probably could have used some extra nutrients. My androgens were like a little high, but nothing super crazy for me. Like for reference, my DHA has been like in the 400s, almost 500s. And my testosterone was like in the 70s at some point. So when I tested them, I was around like I was at 40, which is still under our cutoff of 45. And then my DHEA was still on the higher end of like 250. So I think I was on the higher end. And, also I've been in a really stressful period of time with my business. An amazing growth time. We have so many clients. I'm hiring new practitioners. It's amazing, to have that growth, but that comes with me managing that.
Right.
So I've definitely been in a stressful season, and I think just on top of that and breastfeeding kind of led to those things. But miraculously, we ended up getting pregnant again right after. So my last like menstrual period, quote unquote, if you've been pregnant, they use your LMP, and my LMP was my miscarriage. So I conceived literally the cycle right after, which again, I was not trying to do. I just kind of happened. I wasn't cycle charting just, due to grief and, figuring things out.
Yeah.
Just didn't think I would, conceive. So when I found out I was pregnant, luckily I connected to a NAPRO doctor in my area, got my progesterone tested right away, about like probably 3 weeks, pregnant, super early, and it was 18. And they like to see you around 20. So my provider really left me with the option of do you want to do progesterone or not? Kind of see what happens, because with my 2 previous pregnancies, I did not need any progesterone support.
Right.
And I just decided, progesterone is so safe.
Mm-hmm.
I'd say not easy to do injections in your butt, but it is safe.
Yes.
It
Yes.
is safe. And, I just decided like I'd rather, do that and cover my bases, God
Mm-hmm.
forbid, especially since I got that lab work and I did not have time to replete nutrients more. I
Yes.
did not have the time to work on things as I would have if I did not get pregnant. So
Right.
right now, 7, 8 weeks pregnant, about everything's going good. Looks good so far. So, always after a miscarriage, it's a really weird place to be in. You're just
Sure.
cautiously hopeful,
Mm-hmm.
so I always telling, people say, don't tell people until after the first trimester, but you know what, if I had a second miscarriage, I would tell people anyways.
Right.
So yeah, so that is where we're at right now.
Well, thank you so much for sharing. And I really think it's helpful for people to hear your stance, because you are so well informed into your own health, and to just know sometimes things happen. And like you said, the body is smart and it knows when it is safe to house a baby, and that it has the ability to nurture that baby to just fully, gestation age, or potentially not. And it doesn't make it okay. I want to say it's still so sad and hard, but to right away kind of dive into, okay, how can I optimize this moving forward? And to your point about progesterone, I've mentioned on this podcast before, progesterone progestation, right? And if those levels, to your point, if we don't have at least 3 months to focus on nourishment for those levels to increase prior to conceiving, then yes, an injection is a great way to increase those levels, so that we see it pro-gestation, promote that gestation as a baby continues to grow.
Yeah, and I would say too, like, obviously, I would say it was a really extreme mental roller coaster that we've
Yeah.
been on, to go from like, oh, like, wow, we're pregnant right away, to wow, we're miscarrying. Like, that was
Mm-hmm.
a really horrible emotional time. And I think also a lot of people, what I'd like to maybe see discussed more, it's a hard thing to talk about, but the realities of miscarriage, like how much you're going to bleed and how potentially awful you're going to feel. Like, I had a horrible headache. I felt terrible. I've never had as much clotting as I've ever seen, like those things that just don't get talked about. People just say I had a miscarriage, but they don't talk
Right.
about like the details. And I would say that I'm lucky, but my best friend had actually just gone through a miscarriage a few months before, and like I was texting, to be able to text her throughout my miscarriage was a huge sense of support, because I'm just like, what did this happen to you? And she could be like, yeah, that happened to me.
Mm-hmm.
So that was really, really great to have during that time. And I did write a blog post, for anyone wondering. I have a blog post on my website of like, if you're going through a miscarriage, what to expect, what to do. And I have a separate one of like root causes of miscarriage. And for me, as much as the grief was there, I felt so lucky to know exactly what I needed to do next. I think that is
Mm-hmm.
where I feel so much grief and pain for other women going through it, is that they're told, and my doctor even told me this too, was like, probably just a chromosomal abnormality, like just try to get pregnant again,
Right.
And that was just really sad for me to hear, because there is so much research on things that can impact miscarriage. Again, I have a whole deep dive blog post into that and the different lab ranges I use, you know, blood sugar, insulin resistance, nutrient deficiencies, clotting, like progesterone, so many reasons why a miscarriage could have happened. And
Mm-hmm.
I just don't think that we should, in conventional medicine, they wait 2 to 3 miscarriages to do
Right.
investigation. I think we
Right.
should do it right after one, because why have a woman go through that again if we don't have to do that?
Absolutely. Absolutely.
So, I just felt so lucky in a way, to then be able to feel so informed of my next decisions, and then to say, to be able to then be pregnant again and be like, okay, I'm going to get my progesterone tested now. Like, for me, it was no brainer, easy next steps, but and I'll break this down too, because that's not a common practice in conventional medicine to test and give progesterone. They will very rarely test progesterone. Maybe they'll do it at 8 weeks. And if you have low progesterone, unfortunately, you may miscarry before 8 weeks. So you need to do it right away. And then secondly, it's not conventional way to also prescribe an injection form. Maybe I've fought very hard with some of my clients with their providers to give them just oral progesterone, which is not as effective as injections, but it's better than nothing. So we really need to improve conventional care in that aspect as well. Like progesterone should be first line. I think any woman who honestly becomes pregnant, they should just test progesterone because it's so safe and easy to do. Why would we not save this woman from this heartbreak with an easy intervention?
Right.
So just for anyone out there, you maybe mentioned NAPRO, providers, but NAPRO providers, FEM, those are going to be the providers who are going to be the ones who know to test progesterone and what to do about that. I'll give also background for myself that when I worked for FEM, I used to monitor my patients' progesterone, and I would refill their progesterone. So for me, it was also so familiar of like, I knew exactly what dose to be asking for and all those things. And, I just feel very, I don't know how else to say, but privileged to have that knowledge and, be able to work from that. So trying to pass that on is huge so that other women can have that information as well.
Exactly. And we will link both of those blog posts in the show notes because, miscarriage is a reality for nearly 25% of pregnancies. There of course ranges out there, but about 1 in 4 initially tested positive pregnancies can end in a miscarriage. And so to just understand it is an unfortunate reality of the fertility and trying to conceive journey at times. And so to know that these resources are available to help you get to the root cause without having to go through 2 to 3 miscarriages, which that's exactly the number that I heard from my conventional medicine doctor too. Thank you, Ginny, so much for everything you have shared today, diving into the root causes behind polycystic ovarian syndrome and then better understanding how to balance your hormones through nourishment and nutrition, but also understanding lab work and how normal ranges may not actually be normal and how to find out what's actually optimal for you. Thank you so much. Anything else you want to share with the audience today?
Goodness. Well, I have lots to share.
Yes, I know. We could talk for 2 hours. Like literally there's so much more we could discuss.
Probably, more, even longer. But
yes,
I would just say, I really try to offer a lot of free content on my Instagram, so if you're just someone who you're not ready to dive into one-on work, like please binge my Instagram. Like I create that content for a reason. I give actionable steps there as well. And I think people just don't decide to binge my Instagram. Like you get a lot of information if you binge my Instagram. And I've also recently come out with 4 free guides now. So I have a deep dive into like your gut health and what your gut symptoms are telling you. So how to connect the patterns, like I mentioned to you, like if you're having the bloating right after meals, that could indicate low stomach acid. I have a guide to help you decode your symptoms. I have a 7 red flags if you're trying, or 11 red flags to look for if you're trying to conceive. So, if you're someone actively trying to conceive, maybe looking at those 11 red flags, because that could also help you prevent a miscarriage. I'm trying to think. And then I have my big master's guide to hormones. So it's kind of the breakdown of like your cycle chart. I have like a free training with it. All of those guides also come with nutrition recommendations. And then the last one I just have is for pregnant breastfeeding mamas of like things to be focusing on during that from a nutrition perspective. So I've tried to really put together these free guides in the past year to help people, to get people direction before they do one-on-one work with us. So please go check those out. I spend a lot of time.
Yeah, I know the kind of time that goes into that stuff. So go grab those. I will link everything in the show notes. Ginny, thank you. This was the kind of clarity and compassion that so many women have been craving. So I know that this will be an episode that many women come back to again and again. So share this with a friend who needs to hear it and grab the resources below because we know that so many women in our community need this. We'll talk to you next time.
So much.